Canadian from a small fishing village in Alaska called Hoona, population 750. And I am from the Raven clan. I've been living in Seattle since 1971. And I am the community advocate and elder for the Seattle Native American community on HIV. I have been active in the HIV AIDS field for 36 years. And so my focus going forward has always been long-term survivors of HIV and AIDS and the struggles that we go through, which I feel is never talked about enough because we're not supposed to be here. You know, and when I think about all the troubles I've been through just as I've grown older, I've noticed some things that have come up for me in the area of health, mental health, emotional health that really um, we didn't anticipate when this disease started. And it always baffles me when I think that AIDS is like 41 years old now, 40 years old, that we still um, struggle so much in this area of just getting treatment, just getting research. And so you get the added strength of being a long-term survivor. And that sounds really great on the onset, but underlying is we've been fighting this for me 38 years. And when I think about myself as an example, you know, when I speak to my community, I always tell them, you know, that HIV is preventable. You don't have to get it, and yet our numbers continue to climb. And I tell them it literally changes your whole life. Anything you plan to do is put on the side because all of a sudden you're faced with constant medical appointments, constant labs, constant specialists, constant medications, and it really becomes a vicious cycle. And just focusing on the HIV, you throw cancer, you throw diabetes, you throw heart disease into the mix, and it just really becomes daunting at times. And I began to notice that when I got my first bout of cancer, was that I was just mentally exhausted. You know, at that time, I think I was 35, 32 years into HIV, and it catches up with you. The constant doctor appointments, the constant medications, the constant things you have to do for underlying diseases. And developing cancer was a real eye opener for me because it really slowed me down. And so I think we talk about long-term survivors struggling today. So many of them isolate. And we've had many talks over the past years uh, isolation and what it does to somebody. We all went through it with COVID. We all have some idea of what isolation is. And so it really is living with yourself 24/7. And I think when you look at all of these factors that come into play, it's very easy to see how people can just isolate. And while that's so understandable, it's also detrimental to our health. You know, we are social human beings. We need to socialize. We need to um, have contact with other people. And, you know, it just seems to be something that's a thing of the past with COVID. You know, so many people work from home now. So many people, you know, you hear it on the news all the time. Companies demanding that employees start coming back into the office. And there's just such a struggle. And that mystifies me why I think people would rush back to the office, but for some reason it's a struggle. And so, you know, in the past year, I've struggled with back-to-back cancer. I have heart disease, so I'm on Coumadin. I was hospitalized 2 times for internal bleeding, and I developed sepsis, spent 10 nights in the intensive care unit, coded once, almost died in the past year with all my hospitalizations 6 times. But for some reason, I'm still here. And so I believe it's because my work's not finished. And it is my work that keeps me going because it really, I realized as I was working my way through HIV research, support, treatment, protocols, and adherence, and uh, that the reason Native American community was the most underserved when it came to HIV was that no natives were speaking up, and that really bothered me. And so I decided it was time for me to step up and start showing that there was Native Americans at the table when it comes to decisions about our health, our treatment, and getting the word out to the community that, you know, it you just need to take some precautions and you can prevent a life that I went through just by protecting yourself. And you think that would be an easy sell, but it really isn't because Native Americans believe that HIV and AIDS is a gay disease and they're not gay, so it doesn't pertain to them. And so it's been a constant struggle. And I started um, writing about my experiences. And I was writing it to give the Native perspective on the history of AIDS and what it's done to me. And it started out as a book and it will still be a book, but I think I'm going to do an event at the Seattle Indian Health Board about how we view life. and how the social determinants of health with regard to the Native American population, to look at areas that prevent you from seeing what's important and what's not important. And because I realized last year, I am one of those people that sit and think about something for hours, literally hours. And the one question I've always struggled with in life, literally my whole life, since I came stateside in 1971 and saw how natives were viewed in Western culture down here, because we are so shielded in Alaska. We don't see any of that. And um, I realized that we are the product of all the trauma, historical trauma that we have lived through for generations. That all of the problems that we suffer from, alcoholism, drug addiction, child abuse, wife abuse, um, and the list goes on, is because of all that historical trauma and the way Western culture views Native Americans. It's easy to see, and I think the biggest is when alcohol was introduced to our tribe, when they used alcohol to get the natives drunk so they could take advantage of them. And so I think that going forward, especially with the upcoming administration, I won't get political, I promise, but we have to start taking some serious look at what our life is going to be like after the new president takes office, because the focus has never been on the poor. It's always been on the middle class. And, we need to start um, picking up our bootstraps and start taking care of ourselves. That's the biggest thing I try to stress is nobody's coming to rescue us. And they shouldn't, because we need to do this. And I really want to focus on diseases that are killing us. And, you know, natives have always believed that our bodies were spiritual temples. And we've lost that through the generations. And we need to get not only our warrior spirit back, but we need to start treating our bodies. We need to step back in time, and we need to go back to our old ways and all of our customs that we let go by the wayside. We need to start doing again. And I think I need to find some ways, different ways to get my message across, that not with just in my community, but over the years I've seen in all minority communities that, there are two things that are quite common. People think that because we're not dying by the thousands like we did in the 80s and 90s, that HIV is no longer a death sentence, that the medications are all you need to take if you become HIV positive. And while part of that is true, there are so many factors that, you know, aren't taken care of by the medications, and that is your compromised immune system. It is still wide open to many diseases. And so I'm trying to develop a talk, and you would think I'd have this done by now because I've been doing this for so long, but every time I think I'm making progress, you hit another wall and you say, I didn't see that coming. And so you're in constant, reflection and, you know, working your presentations, which you should be doing anyway, because it's never just one thing that works, it's a combination of things. And so I think within the Native community, there are similarities where fatigue plays a huge role in the Native American community. And that's evident to me because so many of them had just given up the fight and they just go with the flow. And so I think a place to start is by reminding them of our old traditions and how things were done when we were children. We came together as a community whenever there was a problem, and they didn't stop talking about it until they had a solution and they implemented that solution. And back then, there was no such word as can't. And that's what I loved about my community. If we didn't have the funds or it was going to cost something, people reached into their pockets and put money into the project. And so I think it sounds very simple. It sounds pretty ideal, and it will be a struggle because we've let so many of our traditions fall by the wayside as we acclimated more and more to Western culture. So I think that the things that we need to focus on and get across to long-term survivors who isolate is projects that I'm working on. It's like I've been trying to work with the Madison Clinic on developing protocols to treat long-term survivors differently because our needs are greater. And, there is not a focus when a doctor is talking to a long-term survivor that would prompt him to say, how was your social life? You know, why are you isolating? What can we do to help you? And so I think getting the clinic that treats so many people with HIV, and it's not just minorities that struggle with isolation, it's everybody because, we've been fighting this battle for so long. It's like we just can't do it anymore. And so I want to awaken that thing in them that kept them fighting because if you give up, then the battle is lost. And so you need to find the strength somewhere. We all have that inner strength that we fall back on. And when it lapses, we know to do what we need to do to keep that active. And I just, I think about COVID and I think about the isolation. So many of the people living with HIV and AIDS for 30 plus years. It's just, it is exhaustive and they need to take time to heal, but they can't get comfortable in that time. They need to get back and start, you know, taking care of yourself again. And my fear is, because so many of us live alone, I live alone, and COVID came very close to driving me batty. It is, um, I fear so many of them are committing suicide, and the loss of life is always very sad, especially when we could have developed services that step in and say, how are you doing? What can I do for you today? Can I cook you a dinner? So we did such a good job in the early days of our community. And it was really the lesbians that stepped up when nobody would touch anybody with HIV, stepped up and started going and taking care of people living with AIDS. And that opened the door for us to step up and start helping each other. And so I think we really need to get back to that sort of, um, what is the word? We need to get back to that. We need to start thinking about, stop thinking about ourselves, because thinking about ourselves will not do anything. It's when we reach out and help other people that we help ourselves as well. And so we, the big obstacle I think that we struggle with today is we've become such an individualized society. And I see it so much every day where people don't care about other people. There's so many times I've gotten home and, you know, especially in the grocery stores, it's like people bump into me, they step in front of me, they knock my cart, and, it just, you, on the streets, bikes just whiz by you and almost knock you over, and nobody stops. Nobody says, "Excuse me, I'm sorry." And so when I get home, it's like I can see why people isolate. It's when I get home, I say, I don't ever want to leave this place again. But the saving grace for me is I learned early on in my disease that when I close my front door, I leave the world behind me. And I've made my apartment my safe haven. And this is where I rejuvenate. And this is where, I this is where I cry. This is where I swear at God and I have battles with God. And this is where I, heal. And I really think that if we could get a grip, and I do appreciate the organizations out there that are working on this, like Gen Pride. They have a lot of events for seniors and they have meals for seniors. And there are a couple of other organizations that do that. It's just getting the individual motivated enough to get up shower, and go out and attend these events. So my focus is really on elder health, and that's physically, mental, and emotional. And so it's a struggle. It's something I am constantly battling within myself, and I always use myself as an example. You know, I believe that if you see one cockroach, there are a million others that you don't see. And so those are the people that we need to focus on because we shouldn't be going through this in our, I don't know why they call them golden years, but you know, it, we are, and we do. And so we need to adjust how we treat long-term survivors, and we need to take time with them. You know, even if it's during a doctor visit, you know, don't be so clinical. Say, how are you doing? You know, you'd be surprised. You know, you ask somebody that question, how are you doing? It's like just this wave of relief goes through them, and it's like somebody actually cares to ask me how I'm doing. And so that's my focus in my work here in Seattle. And I love it, as I said, and I think it's what keeps me going. And while I don't think I'll see change in my lifetime, I just hope I'm enough to spark change that will happen over generations. I appreciate you giving me this opportunity to talk to you today. I think this is a discussion like so many other discussions need to be discussed, like mental health, suicide, drug addiction. You know, it's our plates are full and we need to start chipping away at them. So thank you for your time.
Hi, Bill. It's Gina Kang over here.
Bye.
Thanks for being here. I know that when we had originally talked, thank you for spending your time with us here and sharing your experiences. I know for us, kind of in the clinical part, when we had talked about this, just wanting to know, what some things we should know about caring for Native older adults living with HIV. And then I know you mentioned some of the challenges of long-term survivors, especially isolation. Is there anything else that you've noticed in long-term survivors, especially those who are getting older?
Well, there's so many things that, you know, that they struggle with. I struggle with walking now, you know, which really is something I never thought I'd ever struggle with because I've been my whole life as a walker. And, you know, so there's a lot of these things that keep people at home. It's like they can't walk or, you know, there's something that they're going through where they need help with bathing and they need help with cooking, they need help with cleaning. And I think that as health workers begin, and I hope they are, looking at long-term survivors of HIV and AIDS, that they start to see, and I hope long-term survivors are sharing with them, you know, the struggles that they're going through. And a lot of the times that we don't see is just the struggles that they are going through on a daily basis keep them at home. And so, it's my walking. I can walk 3 blocks, okay. If I have to walk 4 or 5, then I have to stop and rest for a minute. And I'm walking very slow. And so it's these things that add to the problem because it's these little things that hinder you from like going to a writers group at Gen Pride or going for one of their meals. And because at this point, like over my past year, I was just struggling with staying alive, you know, socializing and attending social functions was put on the back burner because my focus had to be getting better. And so you put everything else that, could be a hindrance to somebody's participating and getting out. It really is daunting. It's like I said, I can see why people isolate because it might not be by choice, but it is by necessity. And so I think there's been discussions about getting the buddy program back, where volunteers become buddies to people who are in isolation. They go over to their place 3 times a week. They play games with them, they help them clean, they cook a meal for them, but they spend an average of 3 hours a visit with them, just talking and just being with them. And, the first thing they're told to do when you greet your person is you give them a hug. And that hug goes such a long ways because that's one of the things people living with HIV and AIDS have lost that human contact. And, you know, it's just, it's a sad situation, but we can't settle in sad. We need to step up and start focusing on what we need to do. And I think the social workers in the clinic, I'm trying to work with the social workers mainly because doctors, you can mention once and God bless the doctors. I love my doctors and I love my treatment team. But if you talk to them about, taking a moment to ask somebody how they're doing or are they struggling with anything, they'll do it a couple times, but they'll go right back to being, doing the clinical stuff when you see them. So I think the social workers need to be the ones that take the helm when they're working. They have the most direct contact with the clients and to ask them. I think they should develop a questionnaire. What are the things you're struggling with today? And look at those answers. And it's much easier for them to write it than to speak it because, a lot of people feel like they can't verbalize it. It makes them feel weak, especially in the Native community. Men, I really hate how men were raised in the Native community, like never to cry, always pick yourself up by your bootstraps, be strong, be the man, but we need we need those hugs. We need those people to come and spend time with because when you are in isolation, you are stuck with yourself and all your fears and all your anxieties and everything that you struggle with is right at the forefront. And we need a break from that. We need to go to a movie, to sit and talk with someone, go out for coffee, things that break up the monotony of being terminally ill. I don't know if that answered your question. I kind of rambled there.
Hey, Bill, Wayne McCormick here. Uh, One thing I've wondered about, you talked a lot about, as we get older, the needs. But, if you listed all the community boards that you've been on and public speaking engagements, it'd take the whole hour. People don't realize how uh, public and activist you've been. In your speaking engagements in the Native American community, do you notice resonance in the younger generations? You tangentially mentioned pre-exposure prophylaxis or PrEP. Do you think people at risk are paying attention to your message? And do you think there's others who are younger who might pick up the kind of activism that you've displayed?
I have to pause here for a second. I didn't realize Dr. McCormick was in the room when he said McCormick. I thought, oh, Dr. McCormick was my doctor for like 25 years. And he has taught me so much about living with HIV. And I'm just blown away that you're here. Unfortunately, um, we don't get many young people at our events. And that's always troubled me. We tried to set up, there is a Native youth group that meets, and we did try to set up an event where I would come and talk to them, but it got canceled. And I fear that the reason it was canceled was because the topic was HIV and AIDS. And so I've been talking with Abigail and other members, uh, the director of the Seattle Indian Health Board, about what kind of programs we can develop to reach the youth, because I think they're shielded from our events by their parents. And so the HIV group at Urban Indian Health Institute has been developing brochures and info packs on HIV and PrEP and the importance of knowing your status. And I think it's going to be a while before, looking at the history of how staunch Native American people are on HIV, before um, we can start to focus on kids. That always is the primary basis of the beginning of my talks when I talk to Native communities is if we want to change the world, we need to begin with the youth. And we need to teach them about every aspect of life, including all the diseases out there and how you catch them. And the most important being HIV, because it is the most preventable diseases that does the most destruction in our lives. And that's just me. I don't know if it is the most destructive disease, but in my life, it has been the most destructive disease. And so I'm hoping that this book that I'm writing, which has literally taken me 50 years to write, and there are um, the reason that is there are things about being native that I'm breaking traditions and by writing this book. And the biggest is we never air our dirty laundry in public. And I am doing that by writing this book. And if I get it published, I would be disowned by my Tlingit community. And so it's a big step. And so there is a section in my book where I write to the youth, and uh, because I run out of ideas about how to reach them, but I let it go for a while, but then it comes back because I really do believe if we want to change the world, we begin with the youth. And thank you, Dr. McCormick, for coming.
Well, thank you, Bill. I mean, it's enormously courageous what you've been doing for so many years.
Bill, would you be okay with taking a couple questions if anybody had them?
Sure.
Right. If anyone has a question, please feel free to unmute. That's preferable. Or if you cannot unmute, you can put it in the chat.
Hey, Bill, it's Gina King again. I know you mentioned, some of the things that would be helpful when approaching, you know, patients or, individuals when they go see their healthcare providers. Is there anything else that, from the provider side that could be helpful in caring for, individuals living with HIV, especially maybe culturally, as from the Native community?
That has been a discussion for so many years, the struggle for cultural, what is the word? Being culture. I lost the term. I'm sorry. It's kind of like the clinics being culturally competent. That's not the phrase, but and you know, I sit on the CAB for Equity and Research with Seattle Children's Hospital. And I think for someplace like the Madison Clinic, which represents so many cultures, for the clinic to become culturally competent, it would just be, I don't think, feasible. And I think from all the talks that I've been to, and I've been to dozens of talks on cultural competency, is when they look at that and they see how daunting it is and they see how much it's going to cost, it's very easy just to let it go. And so what I think, you know, medical schools would be a good point to start teaching, having a set of classes that teach them about working with different cultures, working with different, identities. I've had several doctors who really did not want to treat me because I was gay. They didn't think I deserved treatment. And um, so we, I just have gotten to the point where I say the way you can really get to somebody is be respectful. When you greet them, be respectful and note in their chart what culture they're from. And, it would be nice if we had a native nurse, a Chinese, well, we have Chinese doctors, and if we had representation in the staff from every culture that we treated, um, that would be great. That would be ideal. But I think in the interim, just being respectful to people when they come and put you know, your own beliefs and thoughts aside because the focus is not you, it is the patient you're working with. And it really is going to take a major force and a huge amount of money, which corporations don't want to put into cultural competency, which is why, we struggle with that in the medical industry is, it's like the simple things like that you would never know. Like having a 26-year-old girl sit down with a 71-year-old man and ask him, native man, and talk to him about his sex life. That's never done. And most likely the elder would get up and walk out of the room. And that's the reason. It is the height of disrespect because sex is something natives keep very private. And so it's little things like that. And, I think adaptability is really needed within the minority communities. We have to do our part too. We have to recognize that, okay, this is not ideal, but my health comes first. So, I've got to do my part as well and be respectful to whoever is treating us. And, I've seen many instances, disrespect from patients. And it always surprises me when I see it because I think this person is trying to save your life. It's a mystery to me, but um, in a long roundabout way, I think it's a struggle. It will need more focus and more attention. And I'm happy to sit on the Seattle Children's Cab because they really are working on equity in not only research participants, but researchers as well. And so it's a start. It's a long way to go, and we're still struggling. As you can see from my answer, I'm trying to pinpoint something that works, but I think it's in the works.
Hey, Bill, Wayne McCormick again. Let's get your opinion on something. Medicare is rolling out a new initiative called the Age Friendly Initiative, where doctors and staff are instructed to ask people about the four M's. Have you heard of the four M's in geriatric care? It's asking about mobility. You mentioned the trouble you're having walking lately. Medications. Are you having trouble with all the medicines you're taking? Mentation. Are you having trouble with your thinking or memory? And then what matters, not just advanced care planning, but what matters to you in your daily life. Do you think that would help with the things that you've concentrated on in this talk? Is that a good start, or is that missing the mark somehow?
I think that's an excellent start. I think the more people that join the conversation, and this is the first time hearing about it, so that's kind of exciting. Um, that, it's like stigma in the HIV community. There's global consensus that stigma is the biggest obstacle that we have in fighting HIV. And that's as far as it goes. Nobody talks about it. I have been asking for years, okay, we know stigma is the biggest obstacle. Why don't we sit down and talk about it? The more people involved in the conversation, the more results we might get. But there is that hesitancy. And, you know, I've noticed in my old age, which has distressed me a little, that I'm slipping from being an optimist to becoming a realist. And that disturbs me because I think once you become a realist, there's nowhere else to go. But being an optimist, you always have options. And so I think that is a huge start because uh, I am really excited to hear that because if we can get the doctors to begin that, then we can really hear what, how is our life today? Are we mobile? Are we active? Are we socializing? Are we, so thank you for sharing that. I am going to look into that after this talk because I'm sure there's things in there that I can add to my talks on um, individual, mental, emotional, physical health that, we sorely need at the moment.
Thank you so very much, Bill. I have learned a lot from you in this hour, and I hope it feeds the optimist part of you to hear that I think all of us will come away from this hour changed in some way, and with a greater understanding of older adults living with HIV, of Native Americans living with HIV, and so many other things that you touched on today. And also, what I'll take away is just what a fantastic role model you are for all of us, for advocacy, for just the passion that you have to, be so active in the community and to advocate for what's most important to you and to your community. And I really, really appreciate that. I will also say that one of our fellows, one of our geriatric medicine fellows, is interested in HIV and aging and has spent the year in Madison Clinic and is working on kind of pulling some of this age-friendly work into that clinic. So there are a lot of reasons to be hopeful and optimistic, and all that you've shared with us today helps us have a greater understanding of what we should be moving toward. And I'm so grateful to you for that. And I thank Dr. Kang for inviting you because this has been just a wonderful hour, and I'm very appreciative.
Thank you for having me. I've enjoyed this.
Thank you so much.
Bye, Dr. McCormick.
Okay, thank you, Bill. And Bill, if you have questions about anything related to age friendly, you can reach out to any of us. You can reach out to me to